In our training currently in Uganda, laparoscopy or keyhole surgery has not been part of the curriculum. It is something new.
So we are at St. Francis Hospital Mutorere in Kisoro, southwestern Uganda. There was a friend of this hospital. So Professor Winfried had been working with us, and then he got kind of a donation, a complete set of equipment for laparoscopy. But they didn't have, of course, some few things were missing, and then we looked for someone to fabricate them. That's way back almost 8 years ago.
They didn't manage to really enroll doing laparoscopy. So the Friends of Mutolere had the hope that somebody would go here for a little bit longer time and work together with them to have them really start up laparoscopy as the preferred approach to surgery. The advantage of laparoscopy is a quicker recovery, less complications, and you have less morbidity. Also, there is less scarring inside the abdomen, so the chance that they will come back with a new problem is much lower.
And it is getting on and off. I see the mom is not agreeing with us. What do you think? The mother should come and be involved. Ate ekindi kutekereza neki mwareba.
So trainings are very vital for the life of a hospital. This hospital belongs to the registered trustees of Kabale Diocese. So the Catholic Church owns the land, it owns the buildings, so legally it also employs all the people who are here. Who stays here, it is largely medical staff, those ones who are employed within the hospital that are staying on the compound and their families. Monday morning meeting, we have all of the doctors, we have all of the paramedical staff, and we have all of the in charges of the different departments. So when I say paramedicals in Uganda, that means now the non-doctors, but who are also not nurses. Now these are people who are handling the support systems in the hospital. They are critical in the delivery of health care.
The only vital observation which was affected was the oxygen circulation.
So there are two groups of people who are here. In general, you have got medical students on internship. In Holland, the students look for internship opportunities, so they try to apply through different organizations, and one of the organizations is Friends of Mutolere.
Which came out. So the case
we are serving in a rural setting. You can have a patient, maybe has tonsil hypertrophy, so needs an ENT surgeon. Now I'm a general surgeon. It pushes me to do extra. Of course, in the end, you get a little more of experience that is wider, touching here and there. But it is challenging.
So the most positive thing I encountered when I arrived here is that there was a big willingness to learn. They were really very proactive in the teaching program. So shall we prepare the OR together? Okay, there were no problems with the tower, but you cannot operate without good instruments. We could only do very small, more diagnostic-like procedures. I came back the second time with funding of the Dutch foundation Hofknecht van Vuren. So I found a local supplier and I bought enough to make 2 full sets.
Now it is camera with a source of light.
The screen, the television screen, is a 2-dimensional picture. You don't see any depth, you don't feel any tissue. You feel if you don't have the whole team knowing what's going to happen and the whole team participating in this 2-dimensional operation field.
Our assumption is that we have the patient set on table, represented by our box, and anesthesia has been given. We have the gas cylinder that gives us the CO2. So how would you open the CO2? We open in anti-clockwise. It is something I love personally to teach. Maybe I can't keep quiet about what I know. So I love when I'm interacting with the people and it helps them. They also love it. They have asked for suction machine, so you know that this is the time we need high flow. So please, give us maximum flow. Polycarp, give us maximum flow. Now we have the suction machine, give us maximum flow.
Well, Dr. Bosco is the only surgeon here in Mutolere. His skills in open surgery helped him a lot to gain laparoscopic skills quickly. So as soon as he was trained on the 2-dimensional view and how to use the instruments, he started doing the first interventional procedures, actually.
It is a double win. You are learning laparoscopy, but also she is a big help in the progressing with open surgery with all this experience.
My preferred way to train people is to train him and together with him train the others. Because he knows how to speak to them, he knows how to explain, he knows their level of understanding. He teaches me how to communicate with his staff and with the nurses. The laparoscopic skills have a learning curve. That's why we invented a box. You train not only the individual skills of the surgeon, you train also the skills of the OR assistant. They learn how to work together.
So I think we can start the training because I have shown him how to connect the instruments and yeah.
Super. Dr. Sharon, we're going to simulate a myomectomy. So we're going to put this uterus into the box. You can see that here is the myoma.
So I have to go in with what? Let's see what we can do. Are you seeing my instrument, sir? So zoom in again and you see me. Good, 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 good. This is the small sheath of the myoma and pull it up.
Great.
Then we cut to expose the capsule, you know that?
Yes.
Okay.
Dr. Jerome's skills were really improved by training on the box. You see that his confidence in the procedure grows.
Until we do what? Then a traumatic grasper.
And if you use the stitch on the myoma, take big bites.
Use this hand. You want to use the hand that is dominant? Okay. She's a good trainer, that I can say that. Because the moment you don't lose temper, especially when you are working with people who are less experienced.
And you see how beautiful she's only bleeding a very little bit, eh?
Very friendly. She makes lots of jokes.
You got the myoma out.
Two things are remaining. One is the hemostasis, closing that whole bed, suturing it.
Yes.
And then, of course, getting this one out.
Great. So we need to
She's a great trainer, a great motivating teacher, innovative, because she finds ways of bringing team together. For example, a simple competition of who achieves what, and so it keeps the team motivated.
Are you ready?
Is with
1, 2, 3, go! Stop. Next, Angelo.
Would you like the 6?
yes.
Yes. Set the pressures. Wait. Sheet.
Is that a +1 failure?
This is, yes, this is acceptable. Are we ready? Yeah. 1, 2, 3, go! Stop.
44.
Yeah?
Yes.
The diathermia. If we use diathermia with laparoscopy, we always use 70-70. Show them, because you already know. Teach everybody where should it be put. I'm then starting to understand what Kenneth is like. that he's gonna kill you all. Okay, Kenneth, are you ready?
Yes.
1, 2, 3, go. And out. And out. And put the diathermia now. Last thing is the diathermia. Go, 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 go. And stop. 1:36. Well done, Kenneth. Then for David, the total.
Here, people pay their own health costs.
So it would be, especially in Africa, of great use if they can recover quickly, go back home, go to work. When they have a health cost here, the whole family is affected because there is less money. What kind of complications can we encounter as a team? Not only the surgeon, but also the anesthesiologist. Start managing the problem, but the management of the problem should not only be on your side. That's why you need to shout out. Because the surgeon is actually the one who should do the first step. And what is the first step?
Looks like it must maybe Alex on this.
Because Alex is managing the tower, of course, he knows very well that he should press the button to stop insufflation. But then you still have a pneumoperitoneum, Dr. Bosco, with a pressure of 12, unless you suck out the air immediately. So you need to close your button on the trocar, put in the suction device. Don't pull out the trocars, because then you will not have control over how much air you suck out. I started with very, very easy lectures, but the lecture I gave now was a much more complex. We really need to have the whole team anticipate on reducing complications and being aware of complications. They are not fully educated anesthesiologists. They are nurses who have been trained to do the task of an anesthesiologist. They have to know changes in the human body when we do laparoscopy. We did not encounter any anesthesiology problem until now, because they are also very dedicated. The discovery that the patient is deteriorating because of a postoperative complication or because of a sickness like pneumonia or a urine tract infection was noticed too late. And we started to do the bedside teaching. So every day we trained again the EVS. It's a score by vital signs. And the total score gives you an indication where the patient is in the recovery. Is he safe or not safe? And that was actually mostly done by Dr. Bosco. I trained him and he trained the rest.
The patient may be fully awake, they are talking to you, they seem not to have problems, but when you add it up, you realize that something is going wrong, because when you add it up, it gives you a particular score, which score calls for an action. And that action is at the back of your card. Now, this is early warning score for adults, but of course the call has been emphasized for pediatrics according to different ages. The goal is 1, recognize early, manage early, get good patient outcome, get cheaper care, and then get a lighter workload for you. It is easier to keep patient afloat than to pick them from the ditch. So let's put it in the context. What do we do?
You can give oxygen.
We are trying to implement the early warning score together along with the laparoscopy, and of course joined together. It is magical. It is doing wonders, really. So please know that we are not inventing anything. Yeah? So don't assume anything. Just see and score. That is all. Simple. Some gloves. Nice. Renongota. Okudambira weekend. So what is our respiratory rate now? Listen. What's your name? Esther. Esther, can you measure for us the respiratory rate here? 16 to 20, so it is normal. What did we do with the two?
We need to know the temperature.
The temperature. Oxygen, the oxygen saturation. Respiratory rate. We need the level of consciousness. And what other thing are we interested in that is associated with this? This is a bonus. Did I move with my 1,000? I will give it to you. What is that?
amount of
Ooh, nice. Urine output. Well, we agree that this is the first time we are finding him with the lowest ever. Ever. Having him at 2, there's the emotional part of the patient. The patient is not a chair. He's complaining, talk to them, and also have a connection and know why you're doing what you are doing. I think that is. Mzee, shemerirwa kakasheshi.
You've seen that we have a lot of trainee nurses and we have several different head nurses. And here, if you want someone to do the EVS, you cannot just say, take the EVS, because nobody will move. You need specifically to know the name. You say the name and you say, please, Evelyn, be so kind as to do the EVS for me. So you hand over the responsibility. When they are in a group, they will not take the responsibility or not feel responsible.
Yeah, of course, the culture difference is there. I think initially it was a bit of challenging, but I think she has adjusted. We have adjusted. So of course, you come from here, and she comes from here. You meet in somewhere, and they compromise, and then of course the progress becomes wonderful. Yeah.
The culture difference is always a challenge. Waiting is something that you need to be trained in, and I'm not. So waiting is very, very difficult. Well, Dr. Bosco and also Dr. Jerome, they have had a lot of exposure to European doctors, because more European doctors come here and work here. So I'm not the first one. They know the cultural differences better than I do. So they're used to people like me.
What I have discovered is that they are quite flexible. The most important thing is the flexibility, because you move, you find that the people are different. Maybe they are working, their work ethic is a bit different, but they adapted very fast. And the good thing, of course, is they speak English, so they don't find lots of difficulties.
We pray in the name of Jesus Christ, our Lord. Can we start? Yeah.
Now, Dr. Bahati, zoom in. It makes it easier for Dr. Jerome. Good. Yeah, now we have a beautiful view. Zoom in on the needle and center on the needle.
Well done.
Right now.
Dr. Bahati, when Jerome comes in with an instrument, always show his introduction. Yes, very good, Dr. Bahati. That's the way. Look, he's coming here. Look at his trocar. Yes, super. Much safer.
Very distressing if you are doing an operation and then all of a sudden it goes off. Previously, we had a manual system whereby if power went off in the hospital, someone had to rush to put on a generator manually. Then the system was upgraded and now it is automatic. So a patient may not necessarily die, but you know, the stress that you get, but I mean the confusion that is created.
Do we have blood for the patient? It's a daily problem. And we have nurses who give their blood because we don't have enough blood products. Medication possibilities are very scarce here. Regularly that we cannot have the test on the kidney function because it's out of stock. That's it. Now you're creating a plane. Oops. It's not, isn't it? Put it down. We have 2 OR assistants, and by participating on all the trainings on the box, they've become very enthusiastic. So they don't only give the instruments, but here and there they also use the instruments during the procedure. And that means that we are creating a super good team. What we will try is to see if we also can get some funding to have them officially trained, and it would be lovely if we can have them obtain an official certificate. We managed to implement laparoscopy here in no more than 12 weeks of training. And I'm gonna leave, and they will do it without me, and that's a super result. So what? But of course, there are surgeries even bigger to be done. So next time, we're gonna proceed with the more skilled procedures.
Yes. It is a 1. Temperature is in. A 0. This one is also a 1. You can see our limit is 96. So 1, 1. We store it 17, 1. If yes, of 2. This is good. Let him drink. Let him eat. Keep him in a little bit of fluids, maybe 2 liters in 24 hours. And sit up, sit in the chair like ambulator. Okay. Yeah. Do you remember this patient? From bed number? 7. Nice. You also remember? You see the incision here? Do you see the scar? Very smart. Super nice. Good. This is nice.
We'll continue using laparoscopy so that we don't lose the skill that we have already attained. We are sure that by the time she comes back, if we organize very well, then we should be able to do more than what we are doing.
How many incisions do you see here? We have point incisions. 1, 2, 3, 4. Her abdomen is soft. She's eating, drinking. So we should see her in 1 week, because we need to be sure that her gut is okay. But this is super nice. Bonga box.